So this is a case that was, well, given to me by a colleague from another trust. Okay. So we always start with an S-bar situation. As I said, this is a primate who's presenting to triage at 38 plus 5 spontaneous contractions. Her background, she's 35 years old. She has a past medical history of polycystic ovarian syndrome and was on letrozole when she got pregnant. Antenatally, she had a low PAP-A in her first trimester. What's PAP-A? That protein that comes out of the placenta, so pregnancy-associated plasma protein A. What? We use it for Down syndrome, but okay. What else can it indicate? Okay, can be normal. Or not normal, but it can be that we don't know why it happened. Let's not say normal. Normal is a very strong word. So it's a protein that's produced by the placenta. If it is low, it may mean that placenta is not developing properly. Okay, does that make sense? Guys online, are you still there?
Yep.
Remember, I always like some feedback. I feel lonely. Yes, you are, Joe. Thank you. Okay, so she had low PAP-A, but at 20 weeks, she had normal Dopplers. They also monitored her blood pressure throughout, and it was always normal. But she presented third trimester with recurrent episodes of reduced fetal movements, and that's why she had further growth scans. And they noticed that baby is at 2.8 kilograms, and they were discussing induction of labor. Okay. On the admissions when she came in, baseline was normally around 125 to 130 on the CTGs that she had. We're about to go in to assess this lady. So first part of the assessment, what do you accept as normal for this baby? If we are gonna look at the baby's trace, we're just about to go in and see her. This is the history that we've had. What are the risk factors? Let's start with what are the risk factors, and when, and if everything is normal, what am I expecting is normal?
So babies on the small size have a kind of reduced movements.
Okay.
With the previous low PAP-A. But she's on spontaneous labour, it's not induction. Baby's probably fit for labour at the moment, but there could be some essential insufficiency.
So we're thinking about the risk factor is that this baby, we know that baby is small, there may be an element of placenta insufficiency. So on the back of our mind, or in the back of our mind, we're thinking, is there chronic hypoxia? Right. Yes? Yeah. Okay. Now, what am I expecting on the trace? So where am I expecting the baseline to be? 110 to 160. That's normal range for all babies. Yeah, okay. This is a term baby at 38 plus 5. Okay, so start off with, actually a term, 150 is your upper level of maximum. Yeah, right. Your upper normal is 150. Now, specific to this baby, is there any level, can I make this any more specific to this specific baby at 38 plus 5?
I wouldn't know which way to go. I'm just guessing.
You wouldn't know which way to go. Okay. So poor Joe is the person who's sitting in front of me, hence he's getting all the questions. Can anyone save him, please?
$120 to $140.
120 to 140. Why are you saying that?
Well, actually, I just want to know what the antenatal ones are.
So remember we said that when baby was coming in for reduced fetal movements, the baseline was normally between 125 to 130.
So I'd expect it to be that or a little bit lower.
So I'd expect it to be that. Okay. What about variability? What would you expect variability to be? 5 to 25, so within normal. And I'm expecting cycling to still be there. Okay. Accelerations, are we still expecting accelerations?
Yeah.
Not necessarily.
End of the world, they're not there. It's not as much as they're
So
saying.
Joe is saying no. Fatima is saying not necessarily. So why are you saying not necessarily, Fatima?
Because the baby's in labor, so it might.
Because the woman is in labor. So she's getting contractions and the baby might be feeling the squeeze of the contractions. So not necessarily. Okay. What about decelerations? Do you expect there to be decelerations?
No. There could be some, depends how.
She's contracting. She's coming in spontaneous contractions.
Just,
Yes, I would expect deceleration.
So I can accept decelerations, yes, because there are contractions. There may be some cord compression. Yeah. So this is the trace that I can see. Can you see from there? Can you see? So this is her trace in triage. Do you want to describe it? Do you want to?
Talked about risk already. The baseline is about 1.45.
Yeah, 145 baseline.
Such as cycling in the second half of CTG, there's good variability.
Yeah.
First half is reduced, so keep on for a little bit longer. There's no accelerations, no decels. It's probably normal CTG, but one a bit longer to confirm the good variability.
Okay. Did everyone hear that? So Joe was saying that he thinks the baseline is 145.
Oh, so that's high for
Okay.
this patient.
Variability is fine, but there's cycling. Okay. So he feels that the baseline is a little bit on the higher side. Variability is otherwise fine, and there's cycling. There's not really accelerations there, nor really decelerations, but baby seems to be happy. So in general, it looks like it's a normal trace with slightly higher baseline. Do we all agree?
Yes.
Okay. So based on that, what's your recommendation? More precisely, is this baby fit for labor?
Well, so we said the baseline is 145, and before it was 125 on her last antenatal.
It was 125 to 130. That's usually where it's been on the antenatal CTGs.
I'd say probably the baby's fit for labor.
Okay.
I don't know why the baseline increased. Obviously, given the special circumstances we're about today, all her observations and stuff. So potentially, I suppose.
So her observations are completely normal.
Yeah.
You can see her heart rate there. So mom's heart rate is around 180, 190.
I feel like it's a things fit for labor.
Okay. So Joe feels that the lady's fit for labor, or the baby's fit for labor. What does everyone else think?
I'm a bit suspicious, but I will let this continue.
Are you happy for this baby to go through labor? Do you need any further assessments?
I want to know how dilated she is. Is there any evidence of meconium? The maternal heart rate is raised, but there is no temperature, but the maternal heart rate is very raised. So at the back of my mind, I am thinking, is there an element of infection?
Maternal heart rate is 80 to 90. Why is it raised?
Oh, sorry. Oh no, sorry, I misread that. I thought it was like 100 to 120. That's fine. Yeah, how dilated is she?
She's 4 centimeters.
I would be phoning a friend.
Okay. Explain. So I'm your friend on the other side of the phone. What would you like to do? What would you like to say?
I'm going to acknowledge that the baseline is higher for this baby than expected.
Okay.
But at the moment, I don't have any other evidence of infection.
Okay.
So I am happy to let this baby progress and see what develops, but I will be suspicious of a rising baseline with reduced variability.
Is there reduced variability?
No, but I would be suspicious if the baseline was rising and the variability dropped.
Okay, so you're basically happy to carry on with keeping a very close eye on variability. Is that what you're saying?
Yes.
Is there any signs on this trace that this baby is, whatever is going on, but baby is happy and coping at the moment? Is there any signs that you can see there?
So there are some accelerations, and the variability is good. So
And
those are
they've
reassuring.
responded to your VE, yes?
Yeah.
So that's a good sign. So with their VE, they ARM'd and lots of clear liquid drained. Okay? And they decided to continue with labor. Happy to carry on? Yeah? Can you see from there? Cool. So you are now going to be asked to do the hourly assessments. Let's do it. Let's spread it out between us. Let's not torture Joe all the time. Where do you want to do? So you're walking in and they're asking you to have a look.
Yes, the baseline's about 140. There are accelerations.
Whereabouts?
I think maybe towards the end of the trace. Oh no, that's not. No, actually, no, I'll take that back. There's no accelerations. That's more of the beast. Yeah, very
Shouldering.
Yeah, shouldering. Yeah. Variability is normal. There's evidence of cycling. And yeah, there's the occasional and complicated deceleration.
Okay.
So, yeah.
Happy to carry on?
Yeah, happy to carry on. She's contracting every 4 and 10. Yeah.
Yeah, she looks like she's contracting 4 in 10. She's not on St. Joan, by the way. She's not. She's doing this spontaneously. Okay. So does everyone agree? We're happy to carry on? Baby seems to be doing well. If ever you're squinting to see whether this is an acceleration or not, it's not. Most of the time it's not. It's usually a shouldering. Okay. So an hour later, she's being assessed. Fatima, your turn. Do you want to? She has just had a VE. She's 8 centimeters. Do you want to assess the CTG?
So the baseline is going up a little. So it's 150, 155. There is good variability, but I won't say that there's any cycling. There are decelerations with contractions. I mean, you could get away with saying that that's an acceleration with the VE, but I think it's still okay. Overall, normal.
Okay. Do we all agree? Sarah, I'm not picking on you. I know that you're new to this, so I'll spare you this session. Okay. So we're going to carry on because everybody's happy to carry on. And that's an hour later. And Joe, we're back to you.
So it's an hour later after the centimeters.
Yeah.
It looks like, I don't know if this is good, we've lost variability now. Really, it's not really, variability is 6.05 to me.
So just about 5, I think.
Are we up at 1, is that 150 is the base?
So it's 155 to 160. Yeah.
Having decels with every
Having decels with every contraction.
But recovering afterwards without any shouldering.
Without any shouldering. What does that? What difference does that mean?
Nothing.
Yeah, we're beyond that. We're beyond that level of shouldering.
So yeah, less happy about this trace than.
Okay. What would you like to do?
That's cooler edge, I think. So there's reduced variability, obviously, with the raised baseline, the leg that we're concerned about.
Okay.
Last view is 8 centimeters. Could re-examine, I suppose. Is it an hour later?
It's, sorry, let me check. So she was 14:55 when she had the VE, and it's now 15:30. So literally half an hour later.
Half an hour later. Okay,
Yeah.
so it's probably not quick. Yeah.
What would you like to do? So,
Let's give it a.
come on, guys. Anyone bail him out? This is torture, guys.
I'd carry on.
You would carry on?
Yeah.
Okay. Why?
Because the baseline hasn't risen further. It returns to the baseline. I think there is evidence of cycling. And she's made really good progress. So I think we're closer, hopefully, to be achieving a down delivery, hopefully. Yeah, but obviously, there are factors we discussed in that.
Okay. Online, Fatima and Sarah, did you guys hear that? So Victoria was just saying she's happy to carry on. There is still evidence of cycling. Yes, the baseline has gone up a bit, but the decelerations are short acting and the baseline seems to be stable. So
Yeah, I would agree with that.
okay. The only caveat to that, so the only caveat I would say is, remember that the damage here is not about just the hypoxia. So this baby is not hypoxic enough, but this baby may have chorioamnitis ongoing. Okay, so be very, very cautious when it comes to that, because you are now, you can see that there's hypoxia developing and you already knew that there was a raised baseline. If you're
So
not,
sorry.
say that again.
So is your only suspicion of choreo because of the raised baseline at the beginning?
And it's rising further.
But then how do you know that's not like a gradually evolving hypoxia?
Because she's only started getting proper decelerations and they're not even for that long and they're really brief.
But I would argue that at the end of this CTG at the moment, the baseline...
Come back to pretty much normal.
Yeah.
Okay. Is there any further assessments that you can do?
I mean, maternal obs, this, yeah.
So
No
these are
evidence
for temperature. So this is within the next, so the plan at that point was just carry on. We're happy to crack on and leave it going. This is 2 hours later and her temperature is now 37.5. What do you think about the trace now? We don't like the trace. Okay, tell me why.
So baselines have gone high to like 160, I think now. There is lots of contact, but those decelerations are getting wider, deeper and wider, broader. The variability in the bottom of the deceleration is non-existent. There is variability between the decelerations though, but it's almost spending, you've got your hypoxic element to it as well, it's spending some more time below its baseline.
Okay.
So I want to do a new set of observations, I want to examine the woman, and she's fully then assist her down delivery.
So the team was thinking the same. So the midwife already started giving IV paracetamol and IV fluids just to make sure that we're getting further reviews, and the registrar is in to do a VE. They examine and she's fully dilated, direct away at spines with fresh red bleeding. What would you like to do? She has no pain relief from work. No.
I would take her for a trial and just deliver ASAP.
You would do what?
I would want to just deliver her ASAP, probably trial.
As in move to theatre?
Yeah, because if she's got no analgesia.
Okay. So registrar was a bit more courageous. So decided to go for a kiwi. Okay. This is a kiwi application. And this is the first pull. Second pull vertex is visible and delivered with the third. What do you think the outcome would be? You can't tell which is maternal, which is fetal now. So this is now maternal.
Up to one.
And this is fetal.
Okay, right.
the tricky question. What's the outcome and why? Okay, let's start with the condition at birth. What do you think the baby's condition is going to be like?
I presume there'll be some low APGARs.
Below APGARs. Why?
Don't know. I don't know. I don't like the trace.
So remember the comment we said we don't like the trace. Baseline's gone up. Variability is non-existent in the decelerations, and there's prolonged recovery now. What does that tell you about baby's oxygenation? It's becoming hypoxic. Baby's brain is struggling during the decelerations. Yes. And this is this started at, sorry, I'm jumping back and forth. So this is 1740. Okay. And we can see that the variability is pencil tip at the bottom of this. Okay. I don't want to give it away. So yeah, this is outcome. Okay. So with between 1800 to delivery, which is at almost 1820. Okay, so for the last 40 minutes, the baby has spent what, maybe 3, maybe another minute there, and maybe a bit further if this is actually baby, not mom. I don't really think that this is baby. I think this is actually mom. But baby's probably spent about 5 minutes at the baseline there. Okay, and this baby's variability is really, really poor at the bottom of the deceleration. However, the few minutes that the baby is spending at the baseline, variability, actually this is probably not baby, this is probably mom. Okay, maybe this one is baby. So the time when we are picking up baby, possibly, it looks like variability is trying to come back. So I agree with Fatima. I think this baby is going to be very floppy. Okay, because it's just going through a lot within the last half an hour. Okay, do you think this baby is going to recover quickly, or do you think this baby is going to stay floppy? Okay. Why?
Because it's more of an acute event.
So this has all been happening within the last 40 minutes. Okay, but once we get the baby out and breathing, it should be okay. Yeah. Okay. But remember, there was a background of possible infection there. Okay. So the reality is this baby was born very floppy with a heart rate of less than 100. Okay. But this baby did respond quite quickly to resuscitation. It only required just ventilation breaths, and it just pinked up and perked up. Unfortunately, they weren't able to get gases, but what would we expect the gases to be?
.07. Yeah.
Okay. So would you expect the gap to be large, wide, or close together? Let's start there. Wide, because it's an acute event. Okay. What about the base excess?
I would have thought there'd be loads of signs of compensation.
Okay.
Yeah.
Because
it's more of an acute. There's a hypoxia that's rather on acute.
So if it's an acute, the base excess would actually be low. But if it's an ongoing thing, the base excess would be high. However, we think that this baby might have had an infection. So that would increase the base excess. Okay. But in reality, this baby was small. So this baby was 2.8 kilograms. So pretty much the same weight as when it was scanned at 36 weeks. That's 2 weeks later. And they did not require any further antibiotics later on. But the histopathology did show evidence of abruption and infection. So infection within the baby's cord and pneumocystis. Yeah. Okay. Does that make sense? So I think we were lucky there. If I was to change management slightly, okay, so my thoughts are, can I do something differently there? Okay, or actually, if I want to step even further back, was, can I do some, did I need to do something differently there? If we have a higher baseline, she is progressing well. I'm not planning to intervene and stop her progress. I'm not planning to deliver her. But I can see that baby's temperature is going up based on baby's heart rate. Can I keep this temperature at bay? Because that can make a big difference. Okay, it means that baby's metabolic rate is also back to normal rather than an increased metabolic rate. It means that if baby is being faced by hypoxia towards the end, it can cope with it. Okay, could I have tocalized her when I could see that there is, sorry. So not this one, but the one before. Could I space the contractions out? Could I give her Tubutini? We're thinking, but I don't have any answers. Some yes, maybe. There was fresh red bleeding at VE. So the answer is no, definitely not. Definitely not tocalize. If you tocalize, you separate the placenta. So no, you couldn't have tocalized. So the reality is, yes, I agree with the management towards the end. I agree that, okay, this baby needed to come out, okay? And I agree that I would have delivered there and then. But I also agree with Fatima when she was saying that, well, she doesn't have any pain relief on board. Maybe I need to get her to theater and then deliver there. Okay. Remember, you can do a pudendal block in the room, Fatima. A pudendal block can work for a forceps, can work for a kiwi. And it takes about 5 minutes to administer. So usually quite quick.
But only when you can locate the spines.
Only when you can locate the spines. Yes, please. Otherwise, it's not going to work. But I think this baby was managed well. The only difference, as I said, I would have probably given the paracetamol a little bit earlier, which would probably have given it a little bit more time to work. But I would not have waited on this trace. Okay, because this is not a trace that you can cope with. Hypoxia and chorioamnitis should never mix.
So do you think that if there's a starting high baseline in early laborers compared to their previous fetal heart rates, should you always be suspicious that there is an element of chorioamnionitis?
Yes. You have 3 reasons for a high baseline from the beginning. Yes. 1 that you should not be seeing in England, dehydration. Okay, I see it in Egypt because it's the desert. You guys do not live in the desert. The fact that you get somebody that's bone dry so much that they are tachycardic because of being bone dry, that is not common in England. Okay. The second 2 reasons is chronic hypoxia and chorioamnitis. The baby at the beginning of the trace did not. Okay. But it's still sepsis. So yeah, the baby at the beginning was cycling and it was responding to VE, so it doesn't look like it's chronic hypoxia. That leaves sepsis. Yeah. Does that make sense?
Yeah.
Maybe. Not really. Not convinced.
No, yeah, it makes sense. It makes sense. So the 3 reasons for raised baseline are infection, dehydration, and what's not? And okay, fine.
Yeah. Eddie was saying DKA, which is true. So if there's, I mean, yeah.
You probably know.
I mean, we can also talk about arrhythmia.
Yes, okay, yeah.
Yes.
Yeah.
But I mean, these are the 3 reasons that these are the top of your list. These are always the top of your list. Cross dehydration off. Okay, that's the first thing that you always do. When everybody tells you dehydration, just cross it, put a line through it. Okay, and then tell them no, it's either chronic hypoxia or chorioamnitis. when you see the lady at the beginning. Yeah?
I mean, you say dehydration, but then like we do get hyponatremia from dehydration, especially if they've been vomiting like in their induction phase. So it's not total, I wouldn't cross it out completely.
Hyponatremia from dehydration.
Yeah, like the one we had.
That's not hyponatremia. That's not, no, hyponatremia there is not from dehydration. Hyponatremia happens from overhydration.
Not necessarily.
Why would you get hyponatremia with dehydration?
You can get hypovolemic hyponatremia. But anyway, that's slightly off the point. But as in, like, I won't say I'm going to cross it off my list completely.
Okay, leave it in the shadows.
Okay.
Just for when you practice abroad.